So first of all, thank you for the kind invitation and congratulations to this very nice congress. So as you know, indocyanine in green is a fluorescence dye which is uptaken in hepatocytes and even in tumor cells and non-healthy hepatocytes. And it is secreted by MDR-PO2 into the bile duct from healthy hepatocytes, but this canal is blocked in tumor cells and in non-functional hepatocytes. And for these characteristics, we can use ICG for intraoperative cholangiography, meaning we can image the bile duct, the gallbladder, or the cystic duct, which gives us more safety during cystectomy. And we even can use it for liver perfusion testing during major liver resections to identify the resection margins, like here in a right major hepatectomy. We also can stain the liver segments by direct and indirect staining, meaning when we do a positive staining, a direct staining, we inject it into the pedicles, and when we use a negative staining, we ligate the pedicles and give it intravenously to identify the pedicles. So our focus was on tumor staining by ICG, and we have a different staining on the different characteristics of the tumors, meaning that hepatocytes accumulate ICG based on the blocking of the channel, and tumor cells are stained here in green, and colorectal liver metastases don't accumulate ICG. There's an accumulation like a frame around the tumor by immature hepatocytes. So this is a different characteristic of staining. So there have been some recommendations about ICG. This was an international consensus guideline published in 21, and there was the question addressed if ICG could be helpful during tumor surgery regarding resection margins and tumor identification. And as you can see here, these are the statements. So the recommendation was that it could be helpful for tumors located in the surface, 8 millimeters below the surface of the liver, and maybe it can help in intraoperative tumor staining to identify the margins more better in deeper locations. And there was a second consensus meeting, a European consensus meeting published 1 year ago, and even here the question was addressed if ICG could help to identify tumors and to get better resection margins. And as you can hear, nearly the same recommendations. It can help now, it was 10 millimeters, not only 8 millimeters, and it can help to identify better resection margins in deeper locations. But as you can see, the level of evidence for this recommendation is very low or moderate. So for this reason, we addressed the questions to our registry. If we can do better with ICG in minimally invasive liver surgery, and we have a registry where we collect our data, we addressed the question to patients which were included between 2019 and 22. All patients had to get an MRI and CT scan prior to surgery. We performed a LIMAX test, which is a liver functional testing. The decision for resection was made by a multidisciplinary board, and we did no vascular resection in these cases. So as you can see, we have certain experience of minimally invasive liver surgery, some experience with ICG, which we started quite early in our learning curve, and currently we do most of our cases by the robot. And this is one example why we addressed our question. As you can see, this is a cirrhotic case. There's a HCC, and it's a multifocal lesion. And when we perform intraoperative ultrasound, the ultrasound probe, the connections to the surface is not so good, and it's not so easy to identify the resection margins in these multifocal lesions. So this has been the patients we selected in our cohort. In total, we identified 72 patients, 49 became ICG, and 23 patients matched to this cohort. There were no differences in demographics, in operation time, hospital stay. The LIMAX test did not vary significantly. Most of the cases have been surgery have been performed by the robot, and about 14% of the patients had prior open surgery. There was no difference in morbidity. Clavian morbidity was 12.5% in total, and most of these cases received a drain or something like this, so there was no reoperation, and of course there was no death. There was no significant significant difference between the tumor identities. We had HCCs, colorectal liver mets, and cholangiocarcinoma, some benign disease. There was a quite high rate of tumor fibrosis. 40% suffered from fibrosis, and 14% from strong fibrosis, and 15% had fatty degeneration without significant difference. One of the very interesting questions we addressed, if we can identify additional lesions like this one during surgery, which were not described prior to surgery by ultrasound, CT scan, or MRI. And in fact, we did. We found in 33% by ICG staining more lesions. And of these 37% more lesions, we identified 12% of them were histologically positive, 12% more tumor identification. In the non-ICG group, we performed ultrasound. We do this every time. And here we identified 18% more lesions, and none of these lesions was really invaded by tumors. Also no frozen section with tumor positivity compared to 12% with ICG. So the next question was, does this change the intraoperative strategy? And as you can imagine, when you have such multifocalations like here, this should be a change in intraoperative strategy, and in fact we did. So in 35% we changed the intraoperative strategy compared to 9% with a non-ICG group, which was statistically significant. And in most cases we adapted the resection margin because we had these additional lesions. And when we did so, in 100% of these cases, the resection margin was R0. One other thing is that in 8% of the ECG group, we had to terminate surgery because there was no functional reserve of the rest liver. Another interesting thing is when you use ICG and you identify the resection margin and you remove more specimen, you can use it like intraoperative frozen section for surgeons, what I always say, because you can get an idea if you have clear margins. So this is a colorectal liver metastasis. The gallbladder is adherent. You can resect this liver lesion. It's quite an easy resection. But when you have removed it, you can check with your camera when the specimen is out if there is a clear margin or not. So like here, you can check with the camera if there is a green shining fluorescence on the resection margins, you are too close to the tumor. Next question is, when should we administer ICG, or what are the recommendations? And for tumors, it's 0.5 milligrams ICG per kilogram body weight, 10 to 14 days before surgery, and it should be adapted to the liver function. So what we gave in all cases 0.5 milligram per kilogram body weight ICG in colorectal mets, in HCC, in colorectal cholangiocarcinomas. There was a very good detection rates in colorectal mets and HCC, but in cholangiocarcinoma it's not so easy because when you have the cholestasis around the tumor, it's not very specific. And we asked our surgeon if it was helpful, depending on the time we applied ICG prior to surgery, and they said, okay, 4 to 7 days prior to surgery, this is the most helpful time to give it to the patients, and then we have the major benefit of this application. Next question is, when you have an impaired liver function, you get false positive results, and as you can see here, this is a cirrhotic patients, and you have like, it's star heaven, you can see nothing, we can identify only nodules, but not the tumors. And we correlated this to our Linacs findings, and we figured out that when we have a good Linacs function, you have a lot of positive results, and when the Linacs becomes worse, and this is wrong, this should be positive, we have less positive findings. Another very interesting thing is that ICG can help you in extrahepatic nodules. So these are 2 extrahepatic HCC nodules under the right diaphragm. And you can see there would have no chance to identify these nodules without ICG. But when you stain ICG or when you give ICG, this is also accumulated not only in the liver, but also in extrahepatic HCC nodules. So in summary, I think the impact of ICG green in tumor visualization in invasive liver surgery, it is safe, it is feasible, it is a cheap procedure. Regarding on our survey to the surgeon, it's very helpful. I think we can detect more lesions intraoperatively. In our case, it led to 35% change of the strategy intraoperatively, and this might lead to a higher oncological accuracy. So thank you for your kind attention.
Thank you. Thanks for the presentation. I'd like only one comment or question from the floor. Okay. Oh, okay, only one.
Yes, if the kidney function is impaired, yeah, you should not give it, and in hyperthyroidism is also a problem. So if there is a hyperthyroidism and if there is an impaired kidney function, we don't give it. These are the only contraindications.
Sure.
Roland, thank you very much.
Hi.
Very good talk. So the good message is we find more tumors when using ICG, but you find them only on the surface or just below the surface.
Yes.
That
It's 10 millimeters. Being honest, it's only when you find new lesions.
But you found about 30% more.
Yeah.
Then one has to fear that we also miss a lot inside the liver, deeper.
Could be, of course, yeah. But this is not, also you cannot identify these deep lesions with IAG. It gives you a clue. It gives you a clue about the resection margin, and it is very helpful because you cannot palpate, especially in colorectal mets. When you do it minimally invasive, you see a green shining. Oh, I'm too close. I must move to the other side. But being honest, small lesions deeper than 10 millimeters inside the liver, not detectable by ICG.
But you showed you can see more on the surface, and then we have to.
Yeah. Okay. You're right. Yes. Yes. Might be. Yes.
Good and bad.
Yeah. It's good and bad. Okay. I agree.
Okay. Thank you, Professor Croner.